We are going to talk about hemostasis and their disorders. So first, some normal physiology. We have hemostasis. It is the mechanism that leads to the cessation of bleeding from a damaged blood vessel. There are essentially two types. One is the primary hemostasis and the other is the secondary hemostasis. The primary hemostasis is basically just a platelet plug formation, but it is very weak. And to strengthen this platelet plug, we have the secondary hemostasis, which is also called as the coagulation cascade. So essentially what is going to happen is that there is going to be injury to the vessel wall. Then that is going to cause vasoconstriction. Then we're going to have a platelet plug formation. That will lead to coagulation cascade, and after the blood clot has been formed, it will be removed by fibrinolysis, and then repair will happen. Now I'm going to review this very fastly. So right here you see we have the subendothelial collagen and the endothelial cells that is line, and this is the lumen of the blood vessel, and that's the other wall of the blood vessel. There is going to be endothelial damage, and that is going to expose the subendothelial collagen. This will cause vasoconstriction. Vasoconstriction can be caused by endothelin, calcium, and also backflow or pressure of blood. These all are going to cause vasoconstriction. Then what is going to happen after that is that platelets will swell, and then they are going to form pseudopods, like so. Then after that the primary hemostasis is going to ensue. For primary hemostasis, the first step, there are majorly three steps. The first step is the platelet adhesion. How is that going to happen? In the subendothelial collagen, when it's exposed, there is von Willebrand factors. These von Willebrand factors are derived from the Weibel-Palade bodies. Weibel-Palade bodies. And this von Willebrand factor is going to bind to GP1B, and that is going to bind to the platelets. That is how the platelet is going to adhere to the subendothelial collagen. Then we have the second step, that's the platelet activation. This is going to happen that when GP1B is adherent to the platelets, and the platelets is now going to release ADP. This ADP is going to cause the expression of GP2B3A. Okay, and it is also going to produce thromboxane A2, which is going to activate or recruit more platelets. Then the next step is platelet aggregation. In this, we need one fibrinogen molecule and another platelet. Via GP2B3A molecules, receptor molecules on both platelets with a fibrinogen in between, it is going to form and aggregate. So that is how platelets are going to aggregate, and they're connected. But this right here is very weak, and for this we will now move on towards the coagulation cascade, which is going to convert this fibrinogen into a meshwork rather than a singular molecule, and that is done by secondary hemostasis. For secondary hemostasis, our main goal is this right here. We need thrombin that is going to convert fibrinogen into fibrin, and then that fibrin is going to convert into insoluble fibrin, forming a meshwork. right? So how does that happen? There are two pathways for that. One is called as intrinsic and the other is the extrinsic. The shorter pathway is extrinsic and the longer pathway is intrinsic. I'm going to first go over in extrinsic pathway. Tissue thromboplastins are going to activate factor 7 into 7A, and that is going to activate factor 10 into 10A, and then this 10A is going to activate prothrombin to thrombin. For intrinsic pathway, there is going to be contact activation. We have the 12 factor activation, and then that is going to convert cause the activation of factor 9, and then factor 9 is going to activate factor 10. And this step is assisted by calcium and factor 8A. Now that we have gone over the normal hemostasis, we're going to look at the platelet disorders. We have a schematic view for this. There is one qualitative and qualitative. The qualitative is also called as platelet function defect disorders and thrombocythemia. And quantitative is also called as thrombocytopenia. In qualitative, it is related to the function, and quantitative is related to the number. When we know this, we need to know that in the function, the platelet count may be normal, most of the cases, and that can be low. But bleeding time is always going to increase. In thrombocytopenia, the platelet count is always going to be low, and the bleeding time is always going to be increased. This is going to be the basic lab profile that you're going to witness in patients of both these disorders. Now, examples for qualitative, we have Bernard-Solier, Glanzmann thrombocythemia, and aspirin and uremia. And for quantitative, we have further two divisions. We have megakaryocytic thrombocytopenia and amegakaryocytic thrombocytopenia. In megakaryocytic thrombocytopenia, there is going to be the problem in peripheral blood, while in amegakaryocytic thrombocytopenia, there is going to be the problem within the bone marrow. Now, because there's a problem in bone marrow, we need to know that there's going to be less amounts of megakaryocytes, which are basically the precursors of platelets, right? And because of this, the platelet count is going to decrease, and that happens in aplastic anemia and myelocytic anemia. In megakaryocytic thrombocytopenia, there is going to be a problem in the peripheral blood, and there is going to be increased in the number of megakaryocytes, and the platelet count is going to decrease. That is important because megakaryocytes, bone marrow is normal. But platelets are consumed or are destroyed, or something is happening to the platelet count. That is why the platelets count is decreased. These are further divided into two types, immunogenic and non-immunogenic. In immunogenic, the Coombs test is going to be positive, and in non-immunogenic, the Coombs test is going to be negative. The examples are ITP, HIV infection, and AI in case of immunogenic, and in case of non-immunogenic, it's going to be HUS and TTP. I'm going to detail them in this video right now. So first we have the qualitative platelet disorders in detail. We have two for this, Bernard-Solier and Glanzmann thrombocythemia. So first, we're actually gonna take both of these disorders hand in hand and compare and contrast them. So Bernard-Solier syndrome is because of GP1B deficiency, and Glanzmann is because of GP2B3A deficiency. So you know there's going to be problem in platelet adhesion and platelet aggregation. So right here you see where is the problem for Bernard-Solier. For Bernard-Solier, we have a problem in adhesion right here, GP1B. This is deficient. When this is deficient, the platelets will not adhere to each other. Hence, that is Bernard-Solier deficient in Bernard Solier, while in the Glanzmann thrombasthenia, we have a deficiency in GP2B3A. This is deficient, right? So now what is going to be clinical difference? So first we need to know where is the problem. The problem is in primary hemostasis. It is in primary hemostasis. So because of that, you need to know that as primary hemostasis is problematic, what are going to be the clinical features? The clinical features are going to be skin bleeding and mucosal bleeding, petechiae, purpura, ecchymosis, and epistaxis, easy bruising, gingival bleeding, GI bleed, hemoptysis, hematuria, intracranial hemorrhage. Only in severe cases this will happen, right? But none of these things are going to happen. No, these are not going to happen. These happen in secondary hemostasis disorders, right? So when it's a problem in primary hemostasis, only platelet count and bleeding time is going to be abnormal. But the prothrombin time and the partial thromboplastin time, is going to be normal. These are going to be normal because it's only a problem with primary hemostasis. The secondary hemostasis is normal. So platelet count and bleeding time, they are going to decrease. But you know that in the qualitative problems, we have in Bernard and Solier, right here, I'll show you, that platelet count might decrease and it's really mild. And platelets are large, okay? And bleeding time is always going to increase. Bleeding time is always going to increase. Right, and of course in Glanzmann there is always going to be bleeding time is going to increase, but platelet count is going to be normal. And that is it for qualitative disorders.